with
All right.
Margie.
All right. So I'll start again. And now you saw all of my secret reveals, but pretend you didn't. So anyway, thanks for having me, and thank you for doing this on Pacific time, because we Westerners really appreciate that this morning. So I'm going to be talking about crisis services and crisis systems, and I'm going to be focusing on a lot of collaboration with law enforcement, because given current events, that's an area of mental health care and crisis care that's really been coming to the forefront lately. But I'm going to start with a case, because that is what we clinicians do. And so it's Friday and it's 4:30 p.m. and the phone rings. And that's never good, right? And it's your spouse's boss who needs help with his brother, and it just keeps getting better and better. And you're like, well, why the hell are they calling me? And it's like, well, you're a bona fide mental health expert. You have a particular set of skills that you've acquired over a very long career. And they need help with his brother. He's been texting his family members about how he'd be better off dead. They're afraid he might hurt himself. And he has a legally registered firearm at home. He might also have a drinking problem and need detox. So what do you advise on 4:30 on a Friday afternoon? Well, they play a little Family Feud. So perhaps he should call his psychiatrist or his clinic or his therapist. Well, it's 4:30 on Friday, so this is what's likely going to happen, right? If this is an emergency, call 911. Otherwise, ponder what kind of person would call here in the emergency in the first place, and we'll be with you on Monday. So you call 911. Well, all too often we end up with really dangerous situations when that happens. Go to the emergency room. Well, we all know what happens at the ER. So, well, there's some new crisis center that they just built downtown. Let's take them there. Well, all too often, yeah, I've been there, but all too often, we still have systems where substance use and mental health are considered separate things. And so he's been drinking, he needs detox, and maybe the crisis center doesn't do detox. So they say, go to the detox center. Well, you go to the detox center and they're like, whoa, no, he's suicidal. That's too dangerous for in here. So, what you kind of end up with is this situation where it's easier to get into heaven than to get into psychiatric care. And so, what we need to have is this idea that a behavioral health crisis is an emergency, just like a heart attack or a stroke or a fire is. We wouldn't tolerate this kind of system for those emergencies. So what we need is a systemic response with that same quality and consistency as we have and we expect with these other emergencies. But currently what we have is this situation where you call 911, and if you say I have chest pain, you get an ambulance. And if you say I'm suicidal, you get Chief Wiggin. And not surprisingly, then, you're setting up this situation where, despite law enforcement's best efforts, you're still putting somebody in crisis who's not thinking clearly in a situation with people who are armed and, and used to responding to, things like crimes. So our best guesses with the databases that we have is that about a quarter of officer-involved shootings are linked to mental illness. In addition, there's this phenomenon of suicide by cop, where people actually express a desire for law enforcement to shoot them as their suicide method. And if you're a person of color, then this is magnified even more. And so if you survive the encounter, then it's a pathway to jail. So there's over 2 million jail bookings of people with mental illness each year. And if you look at the table on the left, that's the prevalence of mental illnesses in the general population versus in jail. And you can see it's much higher in jail. And even if people are well-meaning, so say officers are trained in recognizing mental health issues, if they don't have some place to take them, they often take them to jail as the path of least resistance. And there's this myth that, well, maybe if we just get them off the street, they'll get the treatment they need in jail. And that's really not the case. Jails do the best they can, but they really aren't meant to be treatment facilities. And it's estimated by the Office of National Drug Control Policy for substance use treatment, only a quarter of men and 14% of women actually receive formal treatment while incarcerated, what happens is that they're incarcerated twice as long. They're more likely to be assaulted or put into solitary. Their Medicaid gets turned off, and they had a job, they lost it, and they come out and they've got a record. It's harder to find employment. So not surprisingly, they're more likely to be homeless and then more likely to be rearrested. And all of these wonderful outcomes are at about twice the cost to taxpayers if you're having to speak red state and justify why we need to change this. If they do make it to an ER, then there's this phenomenon of psychiatric boarding, which I'm sure y'all have heard of, where people are waiting for hours, sometimes days, for a psychiatric bed. There's little or no treatment going on while the person's waiting, which means that people often default to inpatient when you could have stabilized the crisis, perhaps. And then they wait without much treatment, which then gets people at risk to becoming agitated, assaulting staff, injuring themselves. Huge cost in terms of sitters that have to sit and monitor patients, and just a really bad experience. So we need something better. We need a systemic response that delivers evidence-based care with measurable outcomes in the least restrictive setting that can safely meet that person's need. And it, often this tends to be less costly than these higher levels of care that are all backed up. But currently we don't have that. And why don't we have a national standard for crisis services? Well, there's a few different reasons for that. One is that we don't even have any standard nomenclature. So like Travis was saying at the beginning, where he's trying to define what all types of services that this organization is for, there's just this whole list of terms that mean different things in different communities. And one reason for that is that crisis services are primarily funded by Medicaid, and Medicaid is run by the states. And as they say, if you've seen one state mental health system, you've seen one state mental health system. So the Medicare currently doesn't pay for crisis services. Private insurance tends not to. And so there's really no federal kind of oversight in terms of payment to make things standard. And then another thing is stigma. Again, like we wouldn't tolerate this kind of piecemeal approach for physical health illnesses like heart attack or stroke. There's been some progress towards some national definitions of standards. NASHPD, the National Association of Mental Health Program Directors, released a report called Beyond Beds that talks about how we don't just need to build more inpatient beds. We need to look at the whole systems of care, including crisis. The Crisis Now report talks about an air traffic control capability with mobile crisis stabilization, and phones. The Texas State of Mind did a really good review of the literature. Travis mentioned the SAMHSA guidelines. And there's also, stemming from the 21st Century Cures, the other thing that Act did was create this interdepartmental SMI coordinating committee that was created to advise the federal government on how to align all its different services towards improving mental health care. And one of the recommendations was to define and implement a national standard for crisis care. And so there is an organization called the Group for the Advancement of Psychiatry that has a draft report, should be coming out soon, that doesn't talk just about the services, but also the governance and the finance underlying it. And so hopefully that will be out next year. When I talk about systems, really between systems and services. So this is a slide that I stole from Amazon many years ago, and it does a really nice job of outlining the whole continuum of services that a really robust crisis system has, all the way from the acute response, so our 23-hour units, mobile crisis teams, psych ERs, things like that, to post-crisis follow-up, to early intervention and prevention. And oftentimes, communities, as they're struggling with what to do around their crisis systems, all focus on one or two services. And the services, you need all these services. Like the more services you have, the better. But what you really need, though, is it's not enough just to have them. They need to function together, so that they're working together as a coordinated system towards common goals. And then the whole is more than the sum of its parts. And three key ingredients for having your services organized so that they're functioning as a system is accountability. So who's responsible for the system? If we're saying that we are trying to achieve common goals and common values, then who's holding those providers accountable? Who's determining what those outcomes are? And oftentimes that's tied to how it's governed and financed. Collaboration. So crisis services, more so than maybe other parts of the healthcare system, really have to span many, many different aspects of the community. So from all the way from the health system to jails to schools to 911. So you really need a culture of communication and problem solving amongst many different stakeholders. And then data. Like Travis said, I'm a data nerd. But if we're saying that we're trying to align towards common goals and achieve, common outcomes, how do we know if we're doing that? If we're holding people accountable, how do we hold them accountable? How do we have to know how they're performing? And if we're making decisions or trying to improve things, we need to be doing that based on data. And a lot of this work that's been going on around coming up with standards for crisis services are looking to Arizona as a model for, it's one of the best models for having all these pieces put together. So I'm going to be talking about the Arizona system, but also then talking about, applying that to other communities. But one nice thing about the Arizona system is that this governance and accountability is kind of baked into how we're structured and financed. And so I think it's important to talk about that to illustrate how your financing structure can really drive having systemic approach. So Arizona, just here on the left, I'm going to be talking about Southern Arizona, which is the dark blue part. Arizona is an interesting state. I moved here from Texas about 6 years ago. And when I moved out here, Texas funds Medicaid about how you would expect Texas to fund Medicaid. So I come out to Arizona and there's all this Medicaid expansion and there's all this crisis services. I'm like, this is awesome. And the name of the Medicaid department is called Access. And I'm like, that's so great. It's all about access to care. And then I found out that Access, our Medicaid department, stands for Arizona Healthcare Cost Containment System, which is not exactly the access that I thought that it meant, but it really actually explains a lot of why we've invested in crisis services so much. So Arizona was the last state to have Medicaid, not Medicaid expansion, but just like basic Medicaid. Arizona bought into Medicaid in the mid to late 80s, I believe. And it was in response partially to a lawsuit around mental health. In order to meet the conditions of the settlement, they had to have Medicaid to provide the services, and the legislature wouldn't pass it unless it had the words cost containment in the name. And so we were the last state to have Medicaid, but the first state to have a statewide managed care waiver, meaning that all of the services are contracted out to be managed by a managed care entity. And what that means is that we've never had fee-for-service Medicaid. So someone has always had to be thinking of the system as an actual system. So instead of individual providers just popping up and then just sending bills to the state and having the state pay them, it has to be organized into a system. And so the way it's organized currently is that the state is divided into three regions: the North, the South, the Central, and they put out for competitive bid to be the Regional Behavioral Health Authority. We call it REBA for short. And the REBA for Southern Arizona currently is an organization called Arizona Complete Health. I sometimes call them our benevolent overlords. They then they take all the Medicaid funds for crisis. They take other state funds that are allocated for crisis or for unfunded people. The counties have some funds as well, and the SAMHSA block grants and things like that. And they braid all of that together. So you've got just one entity that is administering that money. And then they contract to various service providers that are all sorts of different organizations, including like us. And so you can see that there's a single point of accountability, and that's baked into how we're funded. What this means for crisis is that there's that centralized accountability someone's planning the system. And then crisis is one of the reasons I like crisis is because the clinical and the financial goals are really closely aligned. So what that means is if what I want as a clinician is I want my patients to not be in the ER, they don't need to be, to not be in jail, and to not be locked up in a hospital if they don't need to be there. And if you're paying for stuff, you want that too, because it's less expensive to have people doing well in the community and using community-based services versus being in the hospital. And so what you have is all these different crisis providers, like all the people in an orchestra, with the Regional Behavioral Health Authority kind of as the conductor. If somebody gets out of line, then they're like, hey, you need to be working with us towards these common goals. When you're talking about reducing law enforcement involvement, there's something called the sequential intercept model that talks about the pathway that a person takes through the justice system. So first there's a 911 call, then there's a police encounter, then they're taken to jail and they're booked and so forth. And there's this idea that the health system, the mental health system, has an opportunity to intercept at each point and try to keep the person out of jail and into care instead. And so this intercept 0 and 1, which is community services like crisis lines and 911 and law enforcement, is really where crisis services are, that's where they act. And so here's an example of how, if you're trying, because how you can have this structure can lead to some strategic service design. So if we're wanting to decrease the involvement of people with serious mental illness in jail, if you think about, and I was saying the clinical and the financial goals are aligned. Well, they are, but if you're the head of Medicaid, like, why do you care if people are in jail or not? Because technically, once someone's in jail, their Medicaid gets turned off. So they're kind of off your spreadsheet. So it actually is good for Medicaid financially if someone's in jail. But all that money comes from the same place ultimately, which is us, the taxpayer. So our governor a while back had this initiative where he had the heads of the different departments meet with each other and share their budgets and come up with these cross-silo goals within the state. And so one of those goals was to reduce the criminal justice costs for people with mental illness. So then Access, our Medicaid, they have that goal. So when they are putting out their bids for people to apply and be the REBAs, they had that as a goal. And that was part of their application process, which was tell us how you're going to keep people with mental illness out of jail. And so then the REBAs, who then have that contract, they have that as a contractual requirement for them. So when they make their subcontracts with providers like us, they put in contract requirements and performance metrics and things like that that are targeted towards reducing justice involvement. So one of the ways to do that is there's this idea that law enforcement, if they have the patients that we want to keep out of jail, then crisis providers ought to treat them as a preferred customer. So they prefer to bring people to treatment rather than to jail. So that means for the crisis lines, there's things that facilitate them transferring 911 calls to them instead of to 911, making it easier for law enforcement to access them. Our mobile crisis teams, if I'm like out in the community and I need a mobile crisis person, if I call the crisis line, they have an hour to get to me. But if law enforcement calls them, they have 30 minutes. So, and then there's some teams that are co-responders. So they're really set up to make it easy for law enforcement to access them. And then our crisis centers, which I'll talk about in more detail, are really set up to be quick and easy for law enforcement. So all of these together, you can see then how that strategy of reducing justice involvement for SMI people can filter all the way down, cascade all the way down through contracting. So another way of looking at this is, one of these common goals is to have care done in the least restrictive manner, which is the least costly. So if you look at this continuum, then things are set up to try to resolve the crisis as community-based as possible. So you've got your person in crisis, they can call the crisis line. The Southern Arizona crisis line gets about 10,000 calls a month. And they have, various clinicians on the phone who can resolve those crises. So they resolve about 80% of those on the phone. They do that via crisis counseling. They also can look up information. The clinics are all required by contract to put appointments into this software that they have. And so, like, if part of what it takes to resolve someone's crisis is at 2 a.m. to say, well, we can get you in to an appointment at 4 o'clock on Thursday, then they can do that. If they can't resolve the crisis on the phone, then they can dispatch mobile crisis teams. And so there's a couple different agencies that actually are those teams, but they're centrally dispatched by the crisis line. So they have like little GPS things on their phone, and they can tell where the crisis teams are and dispatch the closest one. And so if they do a face-to-face, then they resolve about 70% of those in the field. If crisis is too acute for that, then people can go to the crisis facility. The crisis teams can run to the facility, or people can come to the facility. And so that's what I'll be talking about in more detail. And that's, kind of the facilities that many of us are involved with. And so most of the people who have a stay in the crisis facility are able to be discharged to the community without going to the hospital. And then there's various wraparound services to keep people stable in the community. At every point along here, there's that idea that law enforcement's preferred customer. So there's different ways to make that connection easy. So now we have crisis line staff is co-located in 911, so they can intercept calls so that it never ends up with a 911 call taker. It stays with the crisis line. There's also, I was mentioning, the mobile crisis teams have to respond faster for law enforcement. There's also various co-responder teams too, where sometimes they go together. And then the crisis facilities are set up to be quick and easy drop off. So the result of all of this is everything is aligned towards decreased jail, emergency room, and hospital use. Now, in reality, it doesn't look like that pretty schematic. In reality, you've got your officer out in the field, and they have a choice between all of these various services. And so that's where this concept of no wrong door comes into, where we're not expecting an officer to have to know all the different nuances of, well, this program does that and that program does that. As far as the officer is concerned, they can access, and the patient, they can access services anywhere, and then we will figure out where they need to go. We're not going to say, oh, go on some wild goose chase here. That we're going to work with them and try to figure out how to get the person to where they need as safely and quickly as possible. At the center of this for Southern Arizona is the Crisis Response Center, which is a facility that our organization operates. And the CRC was a great example of a community collaboration where the community came together. Pima County had a bond election to build the building, and they really wanted it to be an alternative to jail, ERs, and hospitals. We've been managing it since 2014. The services are all paid for via that REBA funding, but the county owns the building. We serve about 12,000 adults, 2,400 kids per year. It is the main law enforcement receiving center for Pima County, Tucson, with that no wrong door approach where we take everybody. The services include a 24/7 urgent care clinic where people can walk in, say, I'm new to town, I need to be hooked up with services, or I need a bed refill, things like that, get their needs met in a couple hours. There's the 23-hour observation unit, which is kind of the heart of the operation. I'll talk about in more detail. And then there's a subacute inpatient. People can stay for 3 to 5 days for adults as well. It was meant to be a place for the community to come together. So there's space for co-located community programs. Over the life of the building, different programs have been in there, including peer-run post-crisis wraparound programs. We have, not since COVID, but we've been having pet therapy coming in and things like that, some cool stuff. And it's on a really neat campus. It's basically on the campus of the county hospital, which is run by Banner University of Arizona. It's connected to their emergency department via a breezeway. The crisis call center is also in our building, operated by a different agency, but in our same building. The bond also built a 66-bed inpatient psych hospital that's run by Banner University, and that's where most of the involuntary commitments go. And there's a mental health court there as well. And actually, that courtroom does some criminal stuff too, like warrant resolutions and stuff like that. So it's like a real functioning courtroom. Our conflict connections. This is our corporate vision statement, which is we address any behavioral health need at any time. And I put that there not as like an ad, but because that is the philosophy you kind of have to make this work. And when especially around law enforcement, you hear a lot of talk about CIT, crisis intervention training, and that's kind of the solution to this problem of people with mental health issues getting, having bad outcomes with police. And CIT, people often think of it as the training, the 40-hour training that the officers get, which is the centerpiece of it. But if you actually go and dig up the original CIT model that was created in Memphis back in the 80s, CIT is not just the training, it's a community response. And part of that community response is to have a place for officers to bring people. Because if you train officers to say, hey, de-escalate the people with mental illness and recognize that they have mental illness and take them to treatment instead, divert them to treatment, their first question is going to be divert to what? Because like we were saying, if they go sit in ERs forever, like they're busy, they got crimes to fight. They need somewhere where they can get people dropped off quick and easily. And so the CIT model actually talks about what would the ideal mental health receiving facility look like. And it lists these 6 criteria. And I highlighted the 2 in the middle because as we go around the country and help other people, this is what we see people have the most problems with, is this no clinical barriers to care and minimal turnaround for law enforcement. So what our philosophy is that no wrong door, and then we take everybody. There's no such thing in our mind as too agitated or too violent. We actually want those people, because if we are able to do seclusion restraint, which different facilities have different abilities to do that. In our philosophy is we don't like to use seclusion restraint, but we can. And that means that because oftentimes if you can't do that, then that means you don't take patients who might need seclusion or restraint, which means they get turned away. If there's not an alternative like our facility, then they end up in the emergency room where they're not really equipped to de-escalate them. They don't have the space, the staff, the training, and so they end up restrained anyway, oftentimes in a gurney in a hallway, or they go to jail, and jail's really good at restraining people. So we feel that we want those agitated people. We like those people because we have the expertise to de-escalate them and not have to have them in seclusion or restraint. And we have a better chance of doing that. We can take people who are intoxicated, voluntary, involuntary. We tell our nurses to figure out how to say yes rather than look for reasons to say no when it comes to some medical issues. And we never turn law enforcement away. So people always ask, what if they bring you somebody medically unstable? Well, it makes more sense to us to take the person in. And, our CMO likes to remind us that we did go to medical school as psychiatrists. And our staff's all trained in basic life support. And we'll get the person stabilized and transported versus saying, put the medically unstable person back in your unmedical cop car and drive them off the property. So we'll take them, but then we get them quickly sent to wherever they need to be. This shows, when you're really trying to treat law enforcement as a customer, what does law enforcement want? They want to get in and out of there quicker than jail. So they told us Pima County Jail takes 20 minutes to book somebody in. I think it actually takes longer, but we made our goal 10 minutes or less, so that they prefer to come to us. They need their own entrance so that they're not parading people in handcuffs and stuff through the waiting room and, with other patients that are just there. And they need to not be hassled about taking their gun off. Before we took over the CRC, they'd be walking around, they need to make a copy, use a bathroom, get some water, and they'd be walking through the patient care area, and staff would say, can you take your gun off? And then if you ever asked an officer to take their gun off, they don't like it. So they have everything they need back here. There's a gated sally port, so they a buzzer opens, closes behind them, so it's a secure area for people can't elope. They have their own entrance. They buzz the buzzer, and then our admissions team comes and meets them and takes the person off their hand as quick as possible. Actually, the Tucson police don't handcuff as a matter of routine, but if they do, our staff has the handcuff keys, and so we are able to, we work with officers to take them off as a show of you're here for treatment, not, because you're incarcerated. They've got their own office where they can do all of their paperwork and refreshments, and that way everything they need is all right back there, their own bathroom, everything. And so they like that. The 23-hour unit itself is an open area. It doesn't have separate rooms. There's a couple different reasons for that. One is because if people are potentially a danger to themselves or others, the way you keep them safe is you have them under observation. And so everything is open so that there's line of sight to everywhere. They're in recliner chairs overnight. And the other reason it's open is because if you think about what happens in an emergency room if you're in crisis, they put you in a room by yourself. They take all the stuff out of it. They hire a sitter who's supposed to sit there and stare at you and not talk to you about why you're there. And then you basically sit in a room staring at the wall for like 12 hours. And that is not very therapeutic. Before we had meds, we had, milieu therapy. Psych units to this day have that open day room usually, so that, because we know that there's some therapeutic value of having interactions with each other. So people are up, they're able to walk around, and we have groups, and the CRC has a nice outdoor patio also that's secure. And so that there's actually activity going on. You're not just sitting there. So as far as what happens in the 23-hour observation unit, really the main distinguishing feature of it is that we assume that we're going to resolve the crisis, which is really a culture shift. So we don't say, oh, gee, you're really sick, we need to get you on the list for a hospital right away. We assume that we're going to resolve all these crises. And we do that through interdisciplinary teamwork. So we have nurse practitioners or psychiatrists there 24/7. We have peers with lived experience who are doing groups and one-on-one interactions, as well as nurses, techs, case managers, therapists, unit coordinators. We believe in early intervention. So we really keep track of our door-to-doctor time. We're able to do detox or start Suboxone, as well as other non-medication interventions, and really proactive discharge planning. So immediately our case managers are on the phone with the clinic, the person's family, trying to figure out what's going on and what do we need to resolve the crisis. And so most people are discharged to the community the following day, even though when they came in to be on the OBS unit, you pretty much meet medical necessity criteria for inpatient. So danger to self, danger to others, acutely psychotic, agitated, intoxicated, withdrawal, but we're able to prevent a hospitalization for these folks. In an emergency room, they probably would have been waiting and boarding for a bed. Law enforcement is a huge partner, and we actually should be coming out in about 2 weeks. Did a paper with NASHBIT and SAMHSA on the collaborative approaches between mental health and law enforcement, around emergency responses, kind of in response to all of the attention to this issue with the Black Lives Matter movement. But that should be coming out in a couple weeks. But a big part of that is the training of law enforcement. And so Tucson uses, this is kind of the training model that they use, where all officers receive basic mental health training. They receive mental health first aid. Some officers receive CIT because the literature shows that it's actually more effective when you have people volunteer for training versus being voluntold. So they've done all kinds of things to incentivize the training. And 70% of the frontline folks have the training. And then there's various specialized units that receive more advanced training, like motivational interviewing, trauma-informed care. And I can spend like a whole hour on what Tucson Police does, but kind of the main part of their kind of what they pioneered was this mental health support team approach, where they have a dedicated team, which is different than a designated team, where instead of like CIT officers, they're taking robbery calls and all that other stuff too. But they have some training where if they happen to get a mental health call, they have the skills. Well, this team does nothing but mental health work. So they have plainclothes, unmarked cars that are dealing with people in the civil commitment system, doing those transports. They start to recognize patterns, develop relationships with the people that they're working with. And then there's detectives that are actually focused on prevention. This was actually created after the shooting in which Congresswoman Gabby Giffords was shot in Tucson by an individual with schizophrenia who had bumped up against law enforcement but fallen through the cracks and was never connected to treatment. So this was sort of the response to that, was to have detectives who investigate things that aren't crimes, which for law enforcement is a huge cultural shift. Like if you call, if you're robbed, you get a robbery detective. If there's a murder, there's a homicide detective. But there's not typically weird stuff detectives for my neighbor's acting weird. And that's what these detectives do. Some data. So this shows our law enforcement drops per month. And the circles are the turnaround, the median turnaround time. So like I was saying, we keep that below 10 minutes. And one interesting thing, and this is a testament to all the work that Tucson police has been doing, is most places when law enforcement is dropping off, you get most people are brought in on whatever your involuntary hold is. 5150 or Baker Act or, whatever their pink slips, whatever they're called. And here, the light bars are the people that they're bringing in voluntarily. So 2/3 are actually voluntary, meaning that TPD is going out and engaging with people and saying, hey, wouldn't you like to come to treatment? I can take you to somewhere where you can get your treatment. Sometimes they even flag down officers and say, I want to go to the CRC. And one of our docs calls it the Uber police. But I think it's really a testament to how proactively they engage. They've got more outreach teams now that are actually going out and trying to connect people to treatment. And so as you can see on the right, there's more and more people being brought to treatment each year. That's the number of transports each year from TPD. And people go, well, is this good or is this bad? And, they're not bringing people who don't need to be there. So it's really, they're finding people in need of treatment and getting them connected. And so this results in less justice involvement. So early in the course of having their mental health team, they were tracking what they call nuisance crimes. So most law enforcement agencies have these low-level crimes that tend to land our people in jail. Vagrancy, which I don't even know. I still don't know what vagrancy is. Drinking in public, civil disturbance. We're working with this group in Ohio. They have aggressive jaywalking. But there's these lifestyle crimes, nuisance crimes that are kind of used to get people off the street who have mental illness. And you can see those have gone down, started going down and have stayed down over the years. The other thing is just having a partnership between the crisis system and the law enforcement, having this kind of more enlightened approach towards mental health changes how they respond to crisis. So this was news to me, but usually, if someone has, the guy in the case report in the beginning, if someone calls 911 and says, or calls the mental health system and says my loved one is suicidal at home with a gun, or not, and there's an order to pick them up because on this involuntary hold, and the police go and they knock on the door and they say, hey, we need to come and take you to the emergency room or to treatment or whatever. And the person says, no, go away. That is a barricaded suicidal person, which in many jurisdictions is an automatic call to the SWAT team, which my law enforcement buddy says, if they're not going to come out for his 2 plainclothes guys, they're not going to come out for 30 guys in a tank. And so it's just, it's a dangerous situation. It costs a ton of money. And so they just stopped doing it in Tucson. And so you can see it very rarely happens. And so if you're trying to make a case to invest in this kind of stuff, people talk about defunding the police. It's not so much defunding, but having partnerships and then spending your money on things that make sense versus SWAT teams for suicidal people. Since the MIST teams, TPD and the mental health system we've been collaborating on multiple other teams, specialty teams. So I mentioned there's co-responder teams. So that's the cop and the clinician responding together. We found, because we went out and visited LAPD because they kind of pioneered that model. And for them, it made sense to have the cop and the clinician driving around together from call to call in a very dense urban area. We're much more spread out. And so it was made more sense to have dedicated teams that just respond to law enforcement whenever they need them or work with the mist detectives versus spending a lot of time driving around in the car because it's so big here. And they've, we've already kind of, that team sort of moved on from preventing jail bookings to really looking to see, can they engage people voluntarily rather than using the involuntary system. And so since doing that co-responder partnership, they've been reducing the involuntary holds from 60% to 20%. There's a deflection program, which is focused on overdoses. So there's a grant that one of the agencies in town called Kodak has with where it funds a peer to go along with police. And so the police have the option to not arrest people for small amounts of drugs. And so they've connected 1,500 people to treatment instead of arresting them in the first 18 months. And then there's the newest is a homeless outreach team that's really focused on the parks in town. And so they're doing a lot of proactive outreach, and they've collaborating a lot with community stakeholders. And so in this first year, they've housed about 200 people, many of whom had to stop at the CRT on the way. And I'll go through the data really quick because I'm not sure how much time I have. But like crisis, or like Travis said, I'm a nerd and I like data, and there aren't any standard metrics for crisis services. So we use this tool to create our own measure set, which has been adopted by some others, where it's called a critical to quality tree. And you can have copies of this PowerPoint, and this has been published too. But in this tool, you articulate what are your values, what value are you trying to bring to your various customers, and so this is the ones that we came up with, which are kind of similar to the Institute of Medicine's goals for quality of healthcare, which is you want timely care, we want it to be safe, least restrictive in terms of both seclusion restraint, but also discharge into the community or converting people to voluntary status. Effective, we look at readmissions. Consumer and family centered, so we look at patient satisfaction, things like that. Partnership, that's where we look at things like how are we doing with law enforcement? What's our drop-off time for them? How often are we on divert where we can't accept people from emergency rooms, things like that. And our Regional Behavioral Health Authority has actually, so these are our two facilities. We've been using this metric system for a while. And our Regional Behavioral Health Authority has required it there's multiple other 23-hour observation units throughout Arizona, and that are smaller. And the REBA requires the same reporting, so that now you have all these crisis centers that are using the same metric set. So you can look at the whole network and performance, and you're comparing apples to apples. And then kind of want to end with this project that we did around, well, okay, so we want to use data to improve our own care, but what about the whole system? And that's where I like this quote from Brene Brown, where she says, maybe stories are data with a soul. Because what I mean by that is that every visit is a story about how the person couldn't get their needs met in the community. So if we turn those stories into data, maybe it can reveal trends about gaps in the overall behavioral health system that's leading to people needing to come in for crisis services. So when someone comes in and you go, why are you here? And you get answers like this: couldn't get my meds filled because there was some problem with the pharmacy. I can't get my case manager on the phone. Got kicked out of my group home. Like, these are all transportation issues. These are all little root cause analysis of problems in the system. So, we have this data. The Regional Behavioral Health Authority would like to use that data to manage their network, but oftentimes they're working with claims, which, that's the bills. And so those are usually like 90 days out of date at least. And so they're looking like back in time, 3 months, whenever they are looking at their own data. So we developed a method to have them a daily data feed and other reports. Now it's actually real time. And so then they are able to collect that data and combine it with their data to analyze it. And then we meet regularly to go over the trends and, look at things that might need improving. Kind of an example of the power of putting the data together like this is that this is when we first started doing this. And each one of these lines are clinics. So, and the percentage, like we know how many people in our crisis facility at any given time are attached to a certain clinic, but one clinic may be responsible for 100 people and one may be responsible for 1,000 people. So just knowing the number isn't enough. We wanted to know what percent of that clinic's patients are ending up in crisis every month. And so you can see the yellow or the orange line, they're an outlier. And even though it wasn't a huge number of patients because it was one of the smaller clinics, they were struggling. And so, maybe then the REBA can then reach out and try to see what help they need. We've had a project focusing on our familiar faces. That's what we call our high utilizers because it's a little nicer. And so we came up with a definition for familiar face, which is one of our top 20%, was 4 visits in the previous quarter. And we do a monthly rolling report of these people to the REBA. And then the REBA, because they're the payer and they have the authority to kind of, if they call a meeting, people show up to it. So they would convene these multi-agency team meetings where we would staff that patient and figure out what's going on with this person. Why are they in crisis all the time? And then what are they not getting? And then more importantly, what are we going to do differently next time they come? Because we know they're coming again. And then we would flag their charts. And this is an example of the flag, which is pretty simple. It just says don't discharge before ART, which is adult recovery team meeting, with their clinic. And you need to call Jerry, set it up, and there's Jerry, and there's Jerry's cell phone number. And so as a result, the first year we did it, there were 64 people who met criteria for that familiar face criteria. A year later, only 7 of the original 64 actually still met that criteria. And then only 37 total met that. So not only did the original cohort get better, but there was less overall churn as we were doing this process. Here's an example of one of the people, kind of what we did. So this was a lady who would get lonely on the weekends. That would trigger her to feeling overwhelmed. She'd just sort of, be ruminating on her thoughts and get all ginned up and become suicidal. And she'd come to the CRC. And so for her, it's like, well, we know that's when she gets, that's her vulnerable time. So they started to do some proactive welfare checks and calls during those times to help her. And then working also with her partner, who was also in services. And then, when you talk about what we do differently at the CRC, it depends on how you look at her. So on the one hand, you could be like, well, gee, like we keep telling her to go to the clinic. The clinic even assigned her a peer, but she won't go there. She's non-compliant. She's help rejecting. She just can't form a treatment relationship with the people that she needs to. Well, on the other hand, though, you could look at the fact that she comes to the CRC as a strength. She feels safe with us. It's not that she can't form a treatment relationship. She had very good treatment relationships with our staff. She even knew what shifts some of them worked. What we needed to do was help her make that kind of relationship with her clinic. So the clinic had a peer support that was assigned to her who she'd never really met because she was never in the clinic. She was always with us. And so her plan was pretty simple, which was every time she'd come to the CRC, we would immediately call the clinic. The peer support would come down there and meet her. So they sort of develop a relationship. And then, the first quarter that we did it, she had 14 visits. Same time the following year, she only had 1 because she was reaching out to that peer and felt safe with the clinic.
Margie, I hate to interrupt. We've got just a couple minutes left, probably less than 7 minutes or so. And we have a number of questions that came in because this has been a very engaging session and you're activating a lot of brain cells in our staff, in our attendees.
Last slide is that we didn't do this overnight. It took 20 years. So I have a nice little timeline here. And the red stuff, just if you can remember nothing else, is you need a culture of no wrong door, figure out how to say yes rather than look for reasons to say no. And so now I can do questions.
Awesome. And we've got a number of them that came in through the chat. So thank you, attendees, for putting those in. I'm going to try and combine a couple of these to be efficient. How does your crisis center deal with either homelessness or with high levels of acuity and aggression?
So for the high levels of acuity and aggression, so we do not use security. We have behavioral health techs. And our philosophy is that we do a lot of training with them so that they're the behavioral health experts. So we wouldn't then default to people with less training when we need help. We use a training called Therapeutic Options for Everybody, which is like a trauma-informed verbal de-escalation. And then something called Safe Clinch, CLINCH, is the techs have that for their physical stuff. Actually, it was the techs suggested we have a work group on that's always looking at milieu safety that has frontline staff on it. And we used to use CPI, and they actually felt that that wasn't meeting our needs, and so they advocated for looking for something different. And then they do drills, and we look at videos so that we're always making sure that we're improving. For homelessness, I mean, that's the biggest challenge of all crisis centers. And so, we have partnerships with some of the various homeless shelters, just good relationships, and, just sort of figuring out what, each person's sort of an individual, but we try to match them to where we can get them care.
Okay. Do you operate crisis facilities in urban as well as rural areas, and what kind of threshold do you need to make this work, if there is such a threshold, or what's different in the different communities that you work in?
Yeah, so we are the facilities that we ourselves run are in Tucson and Phoenix, but we've helped people in other kind of less populated areas. And yeah, I mean, it's sort of, it just depends on like having, you need the psychiatrist or provider backup at least, but you may not be able to sustain having them there on site. But I mean, it's interdisciplinary teamwork, so it kind of comes down to how you use all the members of the team, and they may not be on site, but that they are still working together.
Okay. We have more questions in, but we got to stay on schedule. Margie, this has been tremendous. What a great way to kick off our conference. Thank you for spending time with us and sharing your presentation. We're very excited to implement some of these ideas in our own shops when we get back there, which for some people might just be a few feet away. So thanks so much for doing this. Everyone, I want to give you the out code for those of you that are tracking